All right, everyone. We've reached our half-hour mark, so we'll go ahead and get started. First of all, I'd like to welcome everyone to this week's installment of our AMSSM's National Fellow Online Lecture Series, sponsored by the AMSSM Fellow Online Education Subcommittee. My name is Alberto Oseguera. I'm one of the assistant professors in family medicine and sports medicine here at UT Health San Antonio. Before we get into our topic for tonight, I just want to remind everyone of our next lecture. We actually have a few weeks off due to AMSSM coming up, but the next lecture will be Wednesday, May 6th at the same time. It'll be running endurance medicine and gait analysis presented by Dr. Reiser. So tonight we have the pleasure of hearing from Dr. Roberto Martinez. Dr. Martinez is a fellowship-trained plastic surgeon with subspecialty training in orthopedic upper extremity surgery and microsurgical reconstruction. Having completed 2 residencies and an additional fellowship, Dr. Martinez has significant experience in all aspects of plastic and reconstructive surgery, including cosmetic surgery and breast reconstruction, as well as hand and wrist surgery. Originally from El Paso, Dr. Martinez has a particular interest in serving the underserved communities here in San Antonio, and is also fluent in Spanish, which helps a lot of my patients as well. So just before we start, I'd like to mention some of the goals of the Fellow Online Lecture Series, which are to serve as your home's program, an adjunct, excuse me, to your home's program educational content, as well as to provide fellows with direct access to educational experiences with AMSSM members and at times invited guest speakers, such as tonight, as well as to assist in your CAQ exam preparation. A few reminders to please mute your device's microphone and to turn off your video. You feel free to submit any questions through the chat function. I'll go ahead and ask questions at the end of the lecture during our Q&A session. And then don't forget to complete the evaluation at the end of the lecture. So one of our new efforts is to facilitate a little bit more input from our audience. There are a few ways to do this. First, there is a web link that can be found by going to amsssm.org. You can click the Education tab and then select the Fellow Online Lecture Series. The link will be near the top of the page as seen in this screenshot here. Second is by scanning this QR code. So it should take you directly to the form to fill out. Just a reminder, when filling out the form, we ask that you please keep in mind that the primary goal of this series is to assist in CAQ preparation for the sports medicine fellows. And this is a new initiative here. Our ultrasound committee is looking to broaden their library and are encouraging AMSSM members to submit cases for the sports ultrasound pathology database. Feel free to email Dr. D'Amico or Dr. Schwanz at the emails above if you have any questions or are interested in submitting a case. So without further ado, we'll let Dr. Martinez go ahead and get started. I'll stop sharing my screen here.
So thank you for that introduction. Again, my name is Rob Martinez. I'm an associate professor of plastic and reconstructive surgery here at UT Health San Antonio. I have no financial disclosures, just throughout this discussion and conversation, I'll be using pictures and statistics from mostly 2 references. The reference on the right is a really outstanding textbook on facial trauma surgery published by Paul Manson and Ed Rodriguez, who are like 2 of the biggest names in craniofacial surgery. And then another really useful quick hit reference for anyone that's in the emergency department or just wants to read a bit more about these injuries is the AO surgery reference that can be found online. It's really great for orthopedic injuries, extremity injuries, as well as craniofacial trauma. So facial anatomy is exceedingly complex, and the spectrum of facial trauma includes both soft tissues and bones. I mean, we could spend an entire hour just talking about the bony facial anatomy. So what I wanted to do is narrow this down to things that would be more applicable to non-surgeons, specifically emergency medicine doctors or those that deal with patients at the initial consultation. So what I'm going to focus on is low energy isolated trauma to the facial skeleton, and mostly in adult patients with an emphasis on ED interventions and when to involve a specialist. Additionally, we'll talk about laceration repair, specifically primary repair done by non-surgeons, not necessarily like flap reconstruction or any of the secondary procedures that we do. But just as a disclaimer, these are mostly my opinions just based on my experience over the last 15 years taking care of these patients. Again, I'm not going to subject you to the torture of talking about panfacial trauma and the various surgical exposures and reconstructive methods. And then also, we're going to skip over pediatric patients because they provide an entirely different set of complications and considerations. We won't be doing a deep dive into anatomy or the such. Um, so in the United States, there are just over 500,000 emergency department visits for facial fractures, with nasal bone fractures being the most common, followed by mandible fractures, and then third, orbital blowout fractures. There is a gender bias with male patients being predominantly under the age of 65 and female patients older than the age of 65. There's a variety of etiologies which can explain these gender biases. Typically, 50% of younger patients will present status post some sort of an assault, which explains the male predominance. And then in the elderly population, the most common reason patients sustain facial trauma is secondary to a fall. Additionally, sports involving propelled objects like golf, baseball, racquetball, etc., make up a significant proportion of these patients, as well as motor vehicle collisions. Now, even though I said we weren't going to talk about high energy trauma, I did think it was worth noting that we do have to at least consider the ATLS survey in any facial trauma patient based on the fact that, facial swelling, bleeding, aspiration of bone and tooth fragments can affect airway and breathing for these patients. So I think even though that's not going to be the focus of this talk, we're going to speak mostly on low energy mechanisms. It was worth mentioning that. In a similar vein of reasoning, I did want to also discuss imaging for these patients. In my personal opinion, I advocate for liberal use of thin slice dedicated facial bone CT scans. I don't think there's really any downside, and it's almost impossible to fully characterize facial fractures without it. It doesn't really matter how good you are at physical exam. And then there's also a risk for associated injuries. Mid-face fractures, for example, are associated with intracranial bleeds and basilar skull fractures. Multiple facial fractures are associated with traumatic brain injuries, and mandible fractures in about 11% of patients are associated with C-spine fractures. So it's important to keep that in mind and get a thorough radiographic evaluation before moving on to the secondary evaluation. Once we've thoroughly evaluated these patients and determined they don't have more pressing injuries, we can begin a more focused exam. You can go top to bottom or bottom to top. However, you can perform a systematic exam to the face looking for visual clues like edema and ecchymosis, making sure that you palpate all areas of the face, looking for areas of tenderness, step-off deformities, etc. Doing an appropriate ocular and vision exam is paramount, as well as external and internal nasal exam. And then, in addition to assessing the skin in the periorbital area, we have to do an intraoral exam because at times there'll be evidence of gingival bruising and visible occlusal step-off deformities in the case of this patient with a clinically obvious mandible fracture. Before getting into more detailed discussion of specific fracture types, I did want to make a couple general comments on consults and follow-up. Now, coverage of facial fractures can be challenging in certain settings. I understand that. So there's a variety of surgeons that take care of these problems to include plastic surgeons, OMFS surgeons, ENT surgeons. And essentially, if you don't have a call arranged at your facility, you just basically have to get them to someone who does this operation. I don't think any one of us is better than the other. Um, my personal opinion is that ophthalmology should be involved for an ocular exam in all orbital fractures based on the not insignificant presence of sight-threatening conditions that are associated with the various orbital fractures. But outside of that, in the non-urgent setting, for most fractures, a 1 week follow-up with an appropriate specialist is acceptable. And if you can't arrange for that, I would seriously consider transferring due to a lack of specialty care or in the case of multi-system trauma. So now beginning with the most common facial fractures, the nasal bones, the incidence for these fractures peaks in early adulthood with various very predictable etiologies to include accidents, assaults, and sports. These patients will present with pain, deformity, and notably airflow obstruction through the internal or external nasal valves. On physical exam, again, it's important to palpate all areas of the face, but focusing on the nose, you're going to palpate the dorsum of the nose, feeling for any instability between the bony and the cartilaginous dorsum. There's an area called the keystone area on the nose that's critical to the structural support of the dorsum, and that's essentially where the nasal bones overlap the upper lateral cartilages, seen in the lower right-hand corner of the slide. The upper lateral cartilages, when you sustain a direct blow to your nose, they can become avulsed, and in doing so, you lose a critical component of the structural support to the dorsum of the nose. So the long-term sequelae for that is the picture in the upper right-hand corner, which is essentially a saddle nose deformity. Once you've completed your external exam, it's important to do an internal exam looking for involvement of the septum. So you're looking for septal fractures, any drainage, blood versus clear. If you have clear drainage out of the nose, you might want to send a beta 2 transferrin to rule out a CSF leak. But really, what we're looking for is evidence of a septal hematoma, which is surgical emergency that requires drainage within 24 to 72 hours to avoid abscess formation and eventually septal necrosis and perforation, which again will compromise the structural integrity of the nose and ultimately lead to loss of dorsal support. And again, that saddle nose deformity that we saw in the previous slide. So just giving you an idea of why this is an issue, trauma to the nasal septum results in a hematoma, which essentially lifts the mucoperichondrium off of the cartilage, off of the underlying cartilage. And that's problematic because the perichondrium supplies the cartilage with blood flow. So once that hematoma gets in between them, it essentially cuts off the cartilage from its blood supply, leading to eventual necrosis and perforation. The picture on the right is a clinical picture of a very obvious septal hematoma. Now, to be frank, I have actually never seen one in practice, but it is the most important thing to check internally for in patients with nasal trauma. So the question then is, what do you do with septal hematoma when you find it? Really, the drainage of septal hematoma is performed via small incisions through that mucoperichondrium that's elevated off of the underlying cartilaginous septum. So you express the blood, you get it out, and after the drainage, you have to find a way to get the mucoperichondrium to stick back down to the cartilage. Now you can do that one of two ways. You can use nasal packing, which is perfectly fine, or if you feel like it's technically feasible, the AO website demonstrates a quilting suture. Now, that's not the easiest thing to do. I have done this before for other reasons. So it's probably not something that you want to try in the emergency department if you've never seen or done it before. So a perfectly reasonable alternative to that is to put in Doyle splint, which are those, silicone clear splints that have the nasal passageways. I prefer those to non-absorbable, just straight packing, because then you don't have to worry about toxic shock syndrome. The definitive management of nasal bone fractures really depends on the severity of the displacement of the nasal bones and the presence of airway obstruction. In a small number of patients with non-displaced fractures without any deformity or airway obstruction, you can observe. I suspect that the patient on the right didn't have any of those things based on how happy she looks to have her little external splint in place. Um, but the role for closed reduction is mostly, geared towards patients that have displacement with some stability, quote, some stability. And that can make it challenging if you don't do this a lot because it's really a judgment call. And that puts a little bit of pressure on the person doing it because, it is true that closed reduction is possible in the emergency department, and revision rates are similar to other settings, but that assumes that it's done correctly and on the right patient. So what I mean by that is your technique has to be sound, and it also has to be on a patient that doesn't have some other complicating factor like a septal fracture that would mandate maybe more, a more specialized person perform the reduction in the operating room, for example. Now, you don't have to do it immediately. A lot of these patients are very distraught by the appearance of their nose, but in terms of long-term outcomes and sequelae, as long as the appropriate management is performed within a week, the long-term outcomes are about the same. One special consideration I wanted to point out is the posterior dislocation of the nasal bones. Now, there are typically two types of injuries. There's a sweeping. I'll go back to the last slide. There's a sweeping blow to the sweeping or laterally oriented blow to the nose that will cause a C deformity. Like for example, the picture above looks like there was, if you're looking at the patient face on, looks like there's a left to right blow, which resulted in a C-shaped deformity. By comparison, you can take a direct blow to the nasal dorsum, resulting in posterior dislocation of the nasal bones. And it's important to identify that on your imaging because the reduction method is going to be a little bit different. And so in this scenario, you're going to get a Freer elevator or some sort of elevator behind each individual bone and lift them up before putting on your external splint. Routine antibiotics for isolated nasal bone fractures are not indicated. There's no meaningful reduction in infection rates, and overall, there's a low incidence of infection. However, there are a few situations that we should consider some antibiotics. If there's associated lacerations with the nasal bone fractures, if you do, find that zebra and decompressed septal hematoma, it's appropriate to start antibiotics. And then again, I kind of briefly mentioned it, but non-absorbable nasal packing predisposes patients to toxic shock syndrome, much in the same way that a tampon would. So you want to start them on augmentin to prevent that. Moving on to the second most common facial fracture, fractures of the mandibles. These are usually caused by young men getting into fights or elderly patients falling. Additionally, there's motor vehicle collisions contribute a significant number of these patients. We have a picture here of our friend Logan Paul after his recent boxing match with Joshua Anthony. And I spotted this from like across the room when I watched this fight because you can see how obvious it is that his teeth are malaligned. And that's an example of malocclusion, which is one, the primary complaint of patients because they can feel it. You can feel a grain of sand in your teeth or basically anything between your teeth. So you can imagine that when your teeth are completely off from where they normally are, it's very obvious. So it's not only is it the primary complaint of the patient, but it's the primary surgical concern. That reestablishment of occlusion is really the whole reason that patients have surgery for this fracture pattern. Now, again, the most obvious thing on exam is going to be malocclusion. Patients will always also have pain and what's known as trismus, which is just difficulty opening the mouth. Additionally, depending on where the fracture line is, they can get numbness of the lower lip and chin due to involvement of the mental nerve that comes it's usually associated with parasymphyseal fractures. One thing I think is, it's sort of a rare situation where I think the jargon actually helps, becoming comfortable with, because when you speak to someone on the phone, calling this consultant, it's good to be able to speak the same language. Typically, mandible fractures are characterized by their anatomic location, whether or not they're unilateral versus bilateral. Over 50% of the time, these fractures will be bilateral because the mandible, along with the base of the skull not pictured there, forms a ring. And it's sort of like, the same way that it's really challenging to break a pretzel in one spot, it's hard to break a mandible in one spot because it forms a ring. And then third, there's a term called favorable versus unfavorable mandible fractures, which refers to the distraction forces in both the vertical and horizontal dimensions caused by the various musculature, typically of mastication, that will either push the bones towards each other and hold the fracture in reduction, or pull the bones away from each other. And so going back to our friend here, you can see that his fracture pattern sort of aligns with figure B. So I would call that an unfavorable fracture pattern of the mandibular body. And knowing that he had surgery for that, that's a very obvious operative indication. So the reality is not many patients with mandible fractures are candidates for non-operative management. I mean, almost all of them need some sort of fixation to stabilize their bite and allow for bony healing. And because of that, there's not really a whole lot to do in the emergency department, but there are things that we can do to optimize the patient prior to surgery. Irrigation and closing any associated lacerations, as well as placing them on preoperative antibiotics, do in fact reduce infection rates and improve the union rate after surgery. So this is one of the I don't want to call it rare, but one of the instances where treating all of these with antibiotics actually does help the patient quite a bit because by definition, these fractures are all open and contaminated by virtue of the fact that they have oral flora essentially bathing their fracture site. Now, as I mentioned, typically if there's no emergent reason to do surgery for facial trauma, follow up with the surgeon within a week is perfectly acceptable. And there's some debate regarding the time to surgery. 1 to 2 weeks is reasonable. I can tell you from personal experience that, these patients don't always come to their clinic visits. So I've fixed these injuries 4 to 6 weeks out. And, depending on how badly they're displaced, sometimes there's been no bony union. So 1 to 2 weeks is reasonable, but it's really whenever the patient shows up, you can fix it. And last in our discussion of facial fractures, we'll touch on orbital fractures. And I wanted to spend a little extra time because there are several conditions that are emergent. These patients will often present with pain, double vision, difficulty moving the eye. On exam, you'll have some obvious things like ecchymosis and edema in the periorbital area, but really the primary concern for these patients is establishing whether or not they have restricted eye movement or any decrease in visual acuity. And if either of those two things are present, or if you have any concern, you're not comfortable doing an exam, I would call ophthalmology immediately because there are several situations that are sight threatening. So, for example, that upper picture demonstrates a very, very obvious muscular entrapment of the inferior rectus. You see that undoubtedly the provider asked them to look up. And you can see the right eye is looking up normally and the left eye is fixed in neutral gaze. And that's very classic. It's not a subtle finding. And so, that's definitely something that you should get a specialist involved for. The physiology behind that is demonstrated in the figures below. So when you have a anterior to posterior directed force on the eye, that force is transmitted into the maxillary sinus. The sinuses are essentially airbags of the face. And so the reason there are characteristic fracture patterns in facial trauma is because the bones break in a predictable fashion because of the sinuses. And so, evolution or what have you designed our face so that if you get hit in the eye, rather than your globe automatically rupturing, it has a decompressive route through the maxillary sinus. So direct trauma to the eye often results in an orbital blowout fracture, which is not uncommon, and doesn't always involve the inferior rectus muscle, but you can see from the figure that the inferior rectus travels on the floor of the orbit, and as such is at risk for becoming entrapped. And when that does happen, it's a surgical emergency because if it remains entrapped for greater than 4 to 6 hours, you can get muscular necrosis and permanent visual disturbances. So then the question is, how do you confirm your diagnosis? This is a figure of a force duction test, and I can tell you it's not the most pleasant exam for a patient to go through. You basically numb their eye with topical anesthetic, and using toothed pickups, you grasp their bulbar conjunctiva, and you force them to look medially, superiorly, and laterally. And any restricted movement confirms your muscular entrapment. A second emergent condition associated with orbital trauma are retrobulbar hematomas, which are, basically exactly what they sound like. It's blood collecting behind your eye as a result of trauma, orbital surgery, or hemorrhage from another reason, like, spontaneous hemorrhage from anticoagulation or something like that. These patients present with eye proptosis and severe 12 out of 10 pain. The most important thing to do in that scenario is to check the intraocular pressures using tonometry. Now, again, I personally wouldn't do that. If I had this patient in my emergency department, I would immediately be on the phone with ophthalmology and getting them to come down to check the patient. Typically, an intraocular pressure of 10 to 18 is acceptable. Orbital compartment syndrome, however, is defined as an intraocular pressure exceeding 30 millimeters of mercury. And the reason this is the cutoff is because at this level, the pressure inside the orbit exceeds the perfusion pressure to the optic nerve and retina, and if left untreated, can result in loss of vision. So this is a true emergency and requires immediate treatment within 60 minutes via lateral canthotomy, which is almost always performed in the emergency department. Now, if only the patients actually looked like this when you're trying to do this lateral canthotomy, they don't come in, they come in proptotic and swollen. They don't come in with, labels on the structures to cut. So basically what I've done in the past is numb them up appropriately, obviously, maybe give them an anxiolytic because working around the eye can really stress people out, especially when they're in pain. But you extend an incision laterally from the corner of the eye, and really, bluntly using tenotomy scissors or whatever you got, you put the tip of your scissors on the orbital rim and cut everything inferior to that until the lid pulls away from the eye. And unfortunately, I don't have any clinical pictures of my own experience because usually when I've performed this operation, it's sort of in a tense situation and patients aren't really like super excited about me taking a picture of them. But it does look, more or less like this. So you can see that the lower eyelid is pulled a good ways away from the eyeball. And basically, you just do this until you feel like it's lax, and then you recheck the intraocular pressures to see if there's been a reduction in pressure. Now, some of the less common conditions worth being acutely aware of involve nerve compression in the posterior orbit. There are two main ones, orbital apex syndrome and superior orbital fissure syndrome, which are similar but different in their etiology and their manifestation. So orbital apex syndrome will have restricted eye movements, forehead numbness from involvement of the trigeminal nerve, and vision loss. Superior orbital fissure syndrome, by contrast, has all of those things minus the vision loss. So both of those require emergent surgery with decompression of the posterior orbit. But now, now that we've talked about the emergent conditions associated with orbital fractures, I think it's also important to discuss the non-emergent surgical indications because those are by far the most common. Radiographic criteria for when to fix an orbital blowout fracture are really not all that well agreed upon. There's some sources that'll say greater than 1 square centimeter. Others will say 50% of the orbital floor. In my experience, you can't really tell. So my practice is to reassess the patient in 2 weeks after all the swelling has gone down and look for persistent visual changes, specifically persistent diplopia, restricted eye movements, and then based my surgical plan on that. Um, uh, Enophthalmos, as I mentioned, is basically the clinical manifestation of increased orbital volume. So typically, as I demonstrated in that figure, we demonstrated in that figure, when you have an orbital blowout fracture, the pressure in the eye from the force um, blows out the floor of the orbit into the maxillary sinus. And what that does is it increases the volume of the orbit. So enophthalmos is essentially a sagging of the eye back into the orbit from the increased volume. Now, a, a posterior displacement of the eye greater than 2 millimeters is associated with double vision. And so usually that's the cutoff I use. You can see it on the worm's eye view looking up their nose, and patients will definitely complain of it. So after you've established that there's a surgical indication, the treatment for most of these fractures is to put a titanium plate on the floor of the orbit. All right, so now we've talked about the three most common facial fractures and what we can do at the point of care in the emergency department. And so I wanted to also talk about primary laceration repair because it accounts for approximately 8 million ED visits a year, 2 million of which are facial lacerations in the United States. As one would expect, they're more common in children due to them being prone to accidents. I basically group these into two categories. There are high energy slash blunt force lacerations that can result in avulsions, stellate lacerations, etc. And oftentimes those are not amenable to direct primary repair in the emergency department. But the things that, we can do to temporize them are irrigate them copiously, and remember that the face has excellent blood flow. So debriding any tenuous appearing tissues in the acute setting is not advisable. The advice I would give anyone in the emergency department, if they have a really bad facial laceration, if they're not going to be the one repairing it, I wouldn't cut anything out. You just save it for whoever is going to do the definitive repair, and let them deal with it, because it's very unlikely it's going to get infected. The only thing that you can do is take away tissue that could have potentially healed. Um, and then once you've done that, just a loose closure just to get them temporized into someone who with a little bit more experience that can close the laceration is the way to go. Now, sharp lacerations from low energy mechanisms, oftentimes are amenable to definitive repair in the emergency department. And I think it's important to identify those because you can imagine it's not always easy to get someone in with a plastic surgeon or an ENT surgeon for a facial laceration. And so if it is amenable to primary repair in the emergency department, it should be done because it expedites patient care. Again, when to call a consultant, I would say you would call plastic surgery, ENT, OMFS, whoever's on face call for any exposed critical structures, lip lacerations across the vermilion to get appropriate approximation, and then temporal lacerations with any evidence of facial nerve involvement, which is a whole nother topic that I just chose to barely touch upon. Additionally, the eyelid and the lacrimal system need specialized care by ophthalmology. The guy on the right probably needs everyone at the same time. So to really the meat and potatoes of this part of the presentation, I want to discuss primary repair done in the emergency department with, on a laceration that is appropriate and amenable to that. So the first thing I'll say is, I started doing this when I was in residency, but my preference is to anesthetize the patient prior to doing anything to them. So I walk into the room, I introduce myself, I've got my little bottle of lidocaine in my pocket. I explain to them what's going to happen. I anesthetize them before I do any irrigation, anything. I just leave them alone for 20 minutes, let the lidocaine kick in, and I've found that patients are much happier that way. The number one reason that patients have pain during laceration repair is not because you didn't put it in the right spot. It's because you didn't give it long enough to set up before you started. So one of the testable factoids that I remember from my plastic surgery and service training exam was that lidocaine is obviously the fastest onset, but it still takes 7 minutes to get any anesthetic effect, and then the epinephrine in lidocaine takes up to 20, 25 minutes to have any sort of clinical effect. So I always use lidocaine with epinephrine. It's not going to cause any additional tissue necrosis. I'm not worried about it. I use it in fingers, faces. I've not repaired any tips of, penises, but I wouldn't worry about that either. There are several ways to optimize the delivery of local anesthetic, though, and ways to reduce pain. So you should use a buffered, warmed lidocaine, buffered with bicarbonate in a 1 to 10 ratio, warmed to body temperature. So if you basically put it in a 10 cc syringe, 20 cc syringe, tuck it in your scrub pocket, walk around for about 20 minutes, the warmth from your chest will warm the lidocaine to body temperature and make it more tolerable to the patient. It's also important to use a small needle and go through the wound subcutaneously. One of the mistakes that not patients, residents, or even faculty make when delivering lidocaine is they tend to put it into the dermis, which can be painful because it causes increased pressure within the dermis, and patients can feel that. So once you inject through the wound into the subcutaneous tissues, you put a bleb in, give it a second, put a nice little wheel in, give it a second. I usually ask the patient to tell me when it stops burning. And then after they tell me it stops burning, I put a little bit more and I keep a leading edge of lidocaine progressive throughout the wound. Additionally, plus or minus on this one, I've used it and it seems like it helps in certain situations, and then in others it doesn't really seem to do much. but counter stimulation. So, for example, if you're suturing a facial laceration, you take something rough like a Raytech or a gauze, and you rub the top of their head while you're putting the lidocaine in, and it sort of like tricks the brain into it. It was interesting putting this talk together. The article on the right I actually wrote in 2020, and I forgot I published it in the Journal of Family Medicine, Family Practice with my attending, who I'm sticking with a needle in this figure, which was very cathartic at the time. So that's my hand and my attending's right arm. Oh, another consideration. So after you've appropriately anesthetized the wound, I think my personal opinion is it's impossible to fully evaluate a dirty wound. And so one of the things that maybe gets me my blood pressure up a little bit is when people will call me from the emergency department and they'll tell me that there's tissue loss and there's all these like crazy things going on, but they haven't irrigated the wound to fully evaluate it because you can't. There's no way you can fully characterize a wound if it hasn't been irrigated yet. So, in addition to that, copious irrigation is also the most important defense against infection. It's more effective than any antibiotic you can give. There's a specific way you do it. I pressure irrigate with a 20 gauge angiocath on a 20 cc syringe using either saline or tap water. They're both equally as effective. You put 500 to 750 cc's of saline or water into a facial laceration, and you'd be amazed at how clean you can get it. So now moving on. So now you've anesthetized it, you've irrigated it. Now we're gonna repair it. So there are some general principles for a good scar, which is essentially, repairing a facial laceration. That's the end goal, is a good scar that the patient's happy with. So generally speaking, you want a tension-free repair with atraumatic technique, and you want to use fine sutures with early removal to prevent poor scarring. There's not really any consensus on the type of suture. You could do 4-0 or 5-0 monocrol versus bicrol for the deep dermal layer. Obviously, you want to have something that's absorbable. You're not going to put, permanent sutures underneath the skin. My personal opinion, though, is that, there's a whole lot of, you know, discussion about what suture to use on the skin. To use a Prolene, to use a nylon, is it a 4-0, is it a 5-0? I think personally, I ascribe to tension-free repair having the most impact on scar formation. So I actually think that the deep dermal layer is the most important layer of the closure, and I think that's supported by the fact that in a randomized controlled comparison out of Vanderbilt and randomized controlled trial out of Vanderbilt and Cincinnati Children's, they compared the cosmetic appearance at 3 months to patients that had lacerations repaired with a deep dermal layer, followed by dermabond, steri-strips, or absorbable sutures, and it was all the same. So I don't think the actual I don't think the final layer, whether you use 5-O-Proline, dermabond, steri-strips, or any sort of absorbable suture, I don't think that's the most important thing. I think the deep dermal layer offloading the laceration repair is what's going to get you that good scar. Um, if you do decide to put Prolene in, that's perfect. That's perfectly fine. It's all about what people are comfortable with, but you need to take it out early to avoid what are known as railroad tracks. And essentially that's prolonged inflammation around the suture and epithelialization actually in the puncture holes from the suture that causes that railroad track appearance and poor scarring. And again, of note, just to mention, there are other studies comparing sutures with dermabond that did report a slightly higher increased rate of dehiscence in the dermabond group. So again, I mean, I think honestly that still supports, my position that the deep layer is the most important layer of closure. So in summary, facial trauma represents a wide spectrum of injuries. Knowing when to call for help and when to expedite care in the ED is critically important. But when in doubt, you can always admit the patient or transfer to a higher level of care and get them the appropriate specialist involved. But thank you. I appreciate the time to talk, and happy to take any questions.
Awesome. Thanks, Dr. Martinez.
Yeah,
That
no worries.
was really helpful. I do have a few questions that were sent to me. So, um, when you talked about the nasal fractures,
Mhm.
you mentioned that you can manage those surgically as well. If somebody sustains a nasal fracture during, like, let's say a football, basketball season, what's the recommendation there as far as time off, if they can fix it after the season, or what's your recommendation there?
Yeah, it's that's always a fun conversation to have because you can't cheat, biology. So fractures take 4 to 6 weeks to heal, period. Doesn't matter who you are. So I always get in a situation where parents will, ask me if they can play, and what they want me to say is like, yeah, it'll be fine in 2, 3 weeks. And my answer is always the same. It's just the biology of the problem. You need 4 to 6 weeks for appropriate bone healing. We're all people, and people are adults, or they can make their own decisions. And if they want to go to back to contact sports with the appropriate precautions, like a face mask or something like that, that's okay. I'm not going to stop them, but I'm also going to counsel them on, permanent deformity that could result from an additional injury, So it's again, those are never fun conversations, but you can't cheat the biology of the problem.
Yeah, for sure. That's always a fun one to have during the season. Um, so a lot of us, at least on this call, do some sideline work. Are there like a top like five things you would make sure like we have in like our sideline kit?
I think lidocaine, lidocaine, some more lidocaine, and then you should get a little bit of extra lidocaine because it's just it always frustrates me, because you mentioned I do hand surgery, but people jam their fingers all the time playing football, basketball, whatever, and it always just blows my mind that the trainers on the side just try to like pull on them. It's one, it's torturing the patient, and two, all you have to do is a digital block with 2 to 3 cc's of lidocaine, and you can get like a real exam on it. So lidocaine in your back pocket is amazing. Just to be a little bit less obtuse with my answers. I guess, I would have some irrigation for lacerations too, because kids get roughed up and you want to get a good look at it. And I don't know. I think with lidocaine and just maybe some splints and stuff, I think you'd be okay. Like I can't really think of anything that's like off the top of my
Sure.
head. Yeah.
Awesome. Um, and then another question that came in for me was you mentioned that you would use a 5.0 for suture repair on superficial tissues.
Hmm.
Um, do you ever recommend like other sutures to have on hand for like a specific part of the face, or is it always 5.0 for anything on the face?
So I think 5.0 is a pretty safe size. The type of suture that you use, will vary depending on where the laceration is. Like for example, if you did like if you repaired an eyelid laceration, I would probably do something absorbable like 5.0 fast cut or something like that, just because, I wouldn't want to dig out sutures. That was actually something I forgot to put in the presentation. There are practical considerations that significantly impact patient care. For example, if you put 5.0 proline in a 3-year-old with a facial laceration, that's going to be problematic when they have to come out at 5 to 7 days in the clinic. So for me, any kid gets absorbable sutures. Like it doesn't matter. Like because I'm perfectly happy to deal with the scar revision, when they're 12 years old or whatever. But there are some practical considerations I think are missed every now and then, like by, putting permanent suture in fingertips also drives me a little bit nuts because those are really painful to take out, especially if you have like someone who had a revision amputation or really bad table saw injury, digging out permanent suture from traumatic lacerations is not pleasant for the patient.
I think that's going to be it, Dr. Martinez.
Yeah,
Um,
cool.
yeah, thank you so much. Excellent lecture, not only obviously for the fellows, but any faculty that hop on after the fact. I'm sure we'll learn quite a bit from this lecture. So I really appreciate it.
Yeah, yeah. It was good to talk with y'all.